the last presentation will be from Indonesia. Dr. Titik Nuryastuti will be presented on the topics of tuberculosis, which is very important opportunistic infection in this region too. So her talk would be on the evaluation of acid-fast bacilli and Xpert MTB RIF for diagnosis of tuberculosis. Lesson learned from Yogyakarta, Indonesia. Please.
Thank you very much for the introduction, and good morning, ladies and gentlemen. It is as an honor for me to be here today for bring this talk, and I would like to thank to the committee for having me today. And my talk will be about evaluation of AFB and Xpert MTB rifampicin for diagnosis of tuberculosis in Yogyakarta, Indonesia. So without further ado, let's get straight to the introduction. As everybody knows, that Mycobacterium tuberculosis is a leading health problem worldwide, which is about 1/3 of the world population infected by this tuberculosis. In Indonesia, TB cases is alarmingly, especially in our remote place. And as we already know from the data from WHO, Indonesia is ranked as the second burden of TB disease. And then let's discuss about the setting of the study, which is located in Yogyakarta province. This is one of the province among 34 provinces in Indonesia, and TB reports vary in our province based on the 5 districts in this province. In addition, Indonesia set a target of achieving TB case about 70%. But in reality, in almost all provinces, case detection of achievement is still very low. As you can see here, the case detection rate in our province is still far from our national target, which is only 28%. And now we are going to discuss about the diagnosis of TB in our place. So conventionally, pulmonary tuberculosis is diagnosed by clinical scenario combined with the finding from the chest X-ray, and from the laboratory point of view, we determine based on smear microscopy and culture. In developing countries such as Indonesia, diagnosis still heavily relies on smear microscopy, which has a lower sensitivity and specificity. And additionally, culture still remains the good standard for the diagnosis of tuberculosis. We should keep in mind that actually MTB culture is very challenging because it's really required sophisticated laboratory infrastructure, and this method is really time consuming, need qualified staff and strict quality control. Regarding to the time consuming, it will lead to the delayed diagnosis and treatment and will increase the morbidity and mortality. In addition, the delay of the culture, it will also lead to the development of secondary resistance and ongoing disease transmission. In 2010, WHO endorsed a novel rapid automated tool which is called Xpert MTB rifampicin, which can simultaneously detect TB and rifampicin resistance only in 2 hours. In our province, it is introduced in December 2012. And it is used to detect TB infection for high-risk TB MDR, TB HIV, and pediatric TB. So in terms of the using Xpert in Indonesia, as already know that, as mentioned in this slide, that in 2016, there are about 82 gene experts available. Among them were placed in 10 provinces in Indonesia, which is considered as high burden TB and HIV. And in our province, in Yogyakarta, which is considered as the 5th rank of TB burden, we have about 8 gene expert equipment. And this is the summary list of TB problem in Indonesia. TB is still a public health problem despite efforts to control it using DOT strategy since 1995. There is still poverty, low level of education that lead people are vulnerable to TB, and the number of cases is difficult to determine because there is no certain data, and also the number of cases of drug-resistant TB is increasing. And therefore, there is an urgent need to strengthen tuberculosis capacity in our province. So our study is aimed to strengthen tuberculosis of diagnosis capacity, to evaluate tuberculosis diagnosis measure, and also to describe the epidemiology of tuberculosis case in Yogyakarta. And this is the material method. So it is considered as a retrospective study, which is start 2013 till 2016. And the data is come from the log and national TB program record. So basically our population is coming from the presumed MDR TB. So we have obtained about 1,329 sputum and 20 non-sputum specimen. All of them are performed for gene expert and AFB smear. And after that, for specimen showing rifampicin resistant cases will be continued for culturing. And in this study, we have about 93 rifampicin resistant positive continue for culturing. And after that, for specimen that grow on the culture will be continued for first-line drug susceptibility test. And now we will proceed to the result and discussion. So as you can see here, among a total of specimen obtained of this study, majority of the population are in their reproductive age. It's about 76%. And mostly the sample comes from male patient. Almost 1/3 of the population, which is around 396 specimen were AFB smear positive. And according to this result, it's about 600 specimen so positive for expert assay for TNA-TB. And among the MTB positive case, it's about 14% were rifampicin resistant. Specimen type of this study mostly coming from sputum, which is about 1,300 sputum, and the non-sputum specimen coming from the pleural effusion, bone tissue biopsy, lymph node aspiration, feces, assay test, and also bronchial lavage and liquor cerebrospinal. And among non-sputum specimen, AFB could not be detected except for lymph node, feces, and feces. And then expert assay was only able to detect MTB DNA from lymph node, assay test, feces, and bronchial lavage. In addition, rifampicin resistant specimen among the non-sputum specimen is coming from the lymph node aspiration. And moreover, this is the result comparing the result from the this is the result of the phenotypic DST. And as you can see here, so among 93 specimens showing rifampicin resistant case, then continue for culturing, and unfortunately only 60 specimens that saw growing on Lowenstein-Jensen media. As you can see here, only 44 isolate saw rifampicin resistant based on phenotypic method, while pan-susceptible, monoresistant, and polyresistant without rifampicin resistant were detected in about this specimen, about 12, 6, and 1 specimen. And in terms of statistical analysis, we compare the result of AFB smear and MTB DNA by Xpert assay. As you can see here, we found moderate agreement between AFB staining and MTB Xpert to determine the TB cases. It is similar with the previous result. So when we compare the phenotypic result between phenotypic method and molecular method, it saw also moderate agreement between Xpert and phenotypic method of drug susceptibility test, which is the Cohen kappa is about 0.5 and consider to the about 80% of the agreement. Yeah. And now talking about the annual detection of TB case in our province, it seems that the presumptive TB cases have been steadily rising since 2013. Similarly, positive cases either with AFB smear or Xpert TB increased as well. The same trend also was seen for Xpert assay diagnostic tool. And for the discussion, I put some statement that Indonesian government aim to eliminate TB as a problem by 2050. But there is still a gap in combating TB, which is we don't have cheap, fast, and accurate diagnostic that can be used for resource-limited setting. And our study found moderate agreement between both diagnostic tests, which is AFB and Xpert, and also Xpert and phenotypic DST. We found also from our study that the proportion rifampicin resistant isolate among Xpert confirmed TB is about 14%. And because the specimen coming to our lab is steadily rising, so it reflects that there is increasing presumptive cases and reflect the Indonesian government effort to expand TB and MDR TB case finding coverage. But we realize that there are a lot of study limitation here, so it doesn't include all identified positive TB cases. Only the DST profile for rifampicin resistant subject were studied, so it may not fully represent MDR TB in general population. No information of cases type, so we do not determine which is it is new or previously treated, which is actually it is important to identify the spreading pattern of MDR TB strain. So the conclusion could be drawn from this study that despite the variation of case detection by AFB smear compared to MTB Xpert, both diagnostic tools were considered as moderately agreeable, therefore should be interpreted cautiously. The study suggested that the increase of MDR TB detection coverage was important to enable better efficiency in detecting TB and MDR TB cases. So I just want to share the picture of our activity and our PSL2 plus lab. So the left side is the picture when we do the AFB smear staining by cell Nelson staining, and the middle part is the procedure of Xpert assay, and the right side is the procedure when we do culturing in Lowenstein-Jensen medium, which is homemade media, and then we directly continue to do the drug susceptibility test by proportion method and lower stain Janssen also, and then we need incubate until 2 months to detect the result. So in Indonesia, actually, there is a campaign which is TOS TB. It is such a reminder for healthcare worker. This approach in Bahasa, TOS means high five. Hence, it is expected that this movement could build a new spirit for all healthcare workers to combat TB. So it is aimed to find TB symptoms, treat TB until treat TB properly, and then monitor TB treatment until healed. And last but not least, I would like to thank to the Ministry of Health of Indonesia for authorizing this project, to the TB team of Special Region of Yogyakarta Health Services, and also for all of hospital staff involved for dedicating their time and support data collection. So thank you so much.